Welcome, everyone. I love seeing a full auditorium like this, especially for a fabulous talk and discussion that I know we're going to have. Um, Here we go. I'm Sandra Stein, the chair of the activities subcommittee that has developed our Triangle Thinkers and Doers series. As you may know, the series was developed in response to requests from residents after we invited David Graham to talk with us about his book, about Project 2025. Residents who attended that lecture asked for more. They told us they wanted an intellectually stimulating series that informs us about the issues of the day. We will have David back next fall for those who missed him first time around to help us get ready for the 2026 elections. But in the meantime, we hope to entice you with other timely topics. Senior pharmacist has been, well, I didn't say, our speaker, as you know, is Gina Upchurch, the founder and executive director of Pharmacist. Senior Pharmacist has been a community partner with the Forest for years, and Gina serves on the Congressional Medicare Advisory Committee, so we were especially glad she could join us to talk about the impact on Medicare of all the changes to health care introduced in the budget and what they mean for all of us. Gina will be talking for about 30 minutes, followed by 30 minutes of Q&A. If you got a card at to write down questions already, if while she's talking or towards the end, you come up with a question you want to ask, just raise your hand and someone will bring you a card to write down the questions. We'll be collecting them at the end of the talk for Diane Sasson, who will be our moderator, to organize and present them to Gina. Please limit your questions to the big picture issues that Gina will raise. Questions about your personal health care can be best addressed through an appointment with Pharmacist. I know my appointment during last fall's open season was extremely helpful to me in making decisions. And now I want to pass the mic to Margaret Keller, who will introduce Gina. Margaret was the first president of the first board of senior pharmacists. She helped with the incorporation. She's fabulous, of course, we all know. So, Margaret, you want to sit down there?
I think you can hear me okay if I stay down here? Okay, good enough. All of us can think back to a time when there was no such thing as Medicare D. And that was a time when anyone who was a senior citizen on limited income had an extremely difficult time putting together the dollars they needed to get all of the medications they needed. In Durham, we just by coincidence had a very good, fortunate situation. One summer, a student, graduate student in the UNC School of Public Health, who had previously gotten her bachelor's degree in pharmacy, decided to come to Durham to be a summer intern at the Durham Senior Center Council, Senior Citizens Council, I'm sorry. And also, while she was there, she shared with the people she was talking with the fact that she was sure this problem could be solved of getting the right kinds of medication at an acceptable price to senior citizens. Fortunately, the person she worked for at the council there, as well as someone at what was then Durham Regional Hospital, agreed with her. And after talking to her, they applied to the Duke Endowment for a grant to see what could be done with Gina Upchurch's idea about how to get medications to senior citizens. That was the first step on the road to what we've now come to call senior pharmacist. Its early years were not smooth sailing, but with Gina's absolute determination to bring local physicians and local pharmacists on board, and with several of us determined that money would somehow be found in the community when the Duke Endowment money began to spin down, Senior Pharmacist was indeed able to survive. It survived for several years in the same situation in which it had begun, supplying basically a credit card, if that's the right word to use, to pharmacists for those seniors with whom they had met and determined what their needs were and what their prescription needs were. But then Medicare D came along, and some people thought, well, now that Medicare D is here, we're not going to need anything like senior pharmacist anymore. But of course, what we soon learned was that the complications for senior citizens of choosing the right Medicare D plan to meet the needs for their particular prescriptions and to meet them at the very least cost possible wasn't an easy thing. And so the staff at Senior Pharmacist began to meet individually with seniors, especially during the open Medicare season, to try to help them choose the very best Medicare plan for them. Last year, Senior Pharmacists helped 1,642 individuals in Durham with counseling about their Medicare D plans, with an average saving of $1,500 for the ones who were able to switch to a better Medicare D plan for their particular medications. They also helped 428 people with direct payment of their copays and worked with 761 of the people whom they saw to help them be referred to other resources in the Durham community that they needed. In the years since this all began, Gina's activity and influence has moved far beyond just the local Durham arena, where she has served on boards like Project Access and Aging Well Durham, to serving as chair of some of the state boards like Long-Term Care Services and Support. Then, in 2023, she was appointed to the Medicare Payment Advisory Commission, MedPAC. That's a nonpartisan commission that advises the U.S. Congress on Medicare policies. This 17-member commission meets 8 times a year in D.C. Gina has just returned from a meeting of MedPAC, and today she's going to use her intelligence, her experience, and I think to some extent her crystal ball to tell us what the future of Medicare may look like.
Thank you both for that, and for the committee that organized. I had a pre-meeting meeting to get ready for today, so they're very organized. So thank you all for doing that. Before I get going, Margaret Keller has been so influential in senior pharmacists. When we were going south financially, she and Vic Moore, who was the other incorporator, many of you know Vic and Ann Moore here, they decided we need to set up an agency fund to keep going when money became thin, and we have needed to depend on it, especially last year and this year with all the crazy things going on. So she gets an official senior pharmacist bag. Okay, now everybody doesn't get that. And for those of you who don't know, Alice Alexander, who's a relatively new resident here, who's on this Thinker and Doer, I call you the Mover and Shakers, but anyway, the Thinker and Doer Committee, helped pass a bond that built the senior center. Now, we pay rent to be in that senior center, but we love having a senior center in Durham. So, Alice, yeah, thank you for your work. Yeah. At the front desk there, you have a couple of things. One of them is probably the best intervention senior pharmacist has ever created, and really one of the best things you can do for your own health. It's a very simple card. We thought the electronic health record was going to take care of all of our business. Everybody was going to communicate with each other. It doesn't happen very well. So this is for you to advocate for yourself. You can put your name on it when you update it, how you get your Medicare coverage, what's the name of your plan, what allergies you have, adverse effects, who your pharmacy is, who your providers are, and phone numbers and your meds. Maybe do these in pencil in case they change, right? And you advocate for yourself. Hey, Dr. Bohr. Hey, Heidi White, Dr. White. You're going to add something? Y'all are so lucky. You have some great clinicians that work here at the Forest at Duke, but I know many of you see outside folk. If you're going to add something, does it go with what I'm already taking? Can you check? Including my over-the-counter and my herbal things. Be sure to write those down. Does it go with these things? Can you take something away or lower the dose of something? For every dollar we spend in the United States, we spend $1.36 fixing problems caused by medications, okay? You have to advocate. We have these med records outside. Please take them. We also have something that looks like a mouse pad, but it's not. It's a jar opener. And it has our phone number, so I hope everyone will take a jar opener. I was using it to get my hose disconnected yesterday from something, so it has many uses, shall we say. And lastly, we have a this is literally hot off the presses. These are the 2026 cost sharing with Medicare. A, B, C, D, you can read all the details, Medigap policies, how they work, what they are. A wonderful handout put out by the SHIP program, Seniors Health Insurance Information Program. If you call 1-800-MEDICARE, if you call the North Carolina Department of Insurance SHIP program, they give you our phone number in Durham because we are the SHIP coordinating site for Durham. Okay? I see so many familiar, loving faces in the crowd. I'm not going to start calling people because I'll miss somebody, but it's painful not to call all of your names. So I was asked to speak briefly and then take questions. So I have the reason people have slides is so they can remember what they were going to say. And I don't have slides, so I had to write it down. Okay. And let's see if I can read my handwriting. First of all, thank you for years of very generous support. As an institution, the Forest at Duke, you gave us $35,000 the last few years. That is huge to us. You are one of our biggest, if not the biggest, corporate sponsor we have. We want Duke to give us more so that they can be the biggest corporate sponsor. But okay. Then a lot of you as individuals give us money. So y'all are just extremely generous. Durham has been so good to senior pharmacists. At one point, Margaret does remember we were struggling financially. We had to call some people and say, this card that we give you, like a prescription card, you use it in any pharmacy and we shrink your co-payments to pay for medicines. We had to call some people and say, I'm sorry, we were letting you have this card, but in 6 months when your time elapses, we can't renew your card. And I remember sitting there on the old-timey phone and looking at Margaret and Vic and saying, I never, ever want to make those calls again. So we have worked hard to try to diversify our funding base, but just the last year or two have been a struggle for lots of reasons. Individuals have been very generous to us, but it's hard to get money otherwise. Okay, how did we get started? Margaret already told you. So the hospital corporation, which used to be the county hospital, was looking to be engaged in the Durham community. And I spent the summer interviewing people, and local clinicians, pharmacists, caregivers said, people need access to user-friendly medicines. Just let them go to their regular pharmacy. We don't need another pharmacy, but we need help paying for it. So we hired a pharmacy benefits manager back in the day so that low-income older adults had some financial assistance. So we shrink their co-payments. Second thing is, we said some people are taking medicines that are probably causing more harm than good, okay? Or they're not taking them correctly, or nobody spent time showing them how to use the inhaler, or nobody spent time speaking to them how to use their glucometer. Nobody spent time talking about What are ways that you can improve your sleep without having to take a medication? So I am one of now 5 pharmacists at Senior Pharmacists that are trained in geriatrics, and that we work with people and providers and other caregivers if need be to streamline drug regimens. Our pharmacists actually have access to Duke's electronic health record. We're totally separate from Duke, but we can look in the electronic health record to see emergency room visits and that kind of thing, so we're doing a good job. But we work super closely with clinicians. So we help pay for medicines, manage medicines, and then came Part D. And the health literacy challenges to understand the parts of Medicare. We call Medicare the equal opportunity confuser. So we don't care what age, what income, because 85% of people on Medicare are there because of age, 65 and older. 15% are younger. They have end-stage renal disease, Lou Gehrig's or ALS, or they've been on permanent disability, Social Security, for 2 years. So we see a lot of people with mental illness, a lot of people with HIV/AIDS that have been on disability for a while. So we do Medicare insurance counseling. I'm seeing so many familiar faces. It's so hard not to call out names. We help all ages, all income with Medicare. In fact, we are working out a plan to have a van from here, because we used to do this in the past, from the Forest at Duke, bring a cadre of you all for appointments, and the van can go back and forth during the Medicare open enrollment period, so we can try to get as many of you in as possible for appointments during the open enrollment period. The other thing that we do is help people navigate social services. You think healthcare is complicated, try social services. How do you get food assistance, housing assistance? So we have 3 people on staff that really help people navigate so that we're user-friendly as can be in helping navigation. That's what we do. How do we do it? Well, we have 3 basic tenets. One is continuity of care. So we see people year after year, some people 3 times a year. So we get to know people. When COVID hit, we pivoted to telephone reassurance to see if people had food and that kind of thing. And several of the people said on the very first day we started making calls, I knew you would call, even though we'd never done telephone reassurance in the past, but they knew we would be part of their team, right? The second thing is using a racial equity framework. And what I mean by that is that some of us have had more advantages than others. So are there ways that we can ensure that everybody feels comfortable coming to senior pharmacists, and that we have people at the decision-making tables that have very different lived experiences? So that's really important to what we do. And lastly, we use motivational interviewing. And what that means is I'm not going to tell you everything I think you should do and how you should be, and I'm going to listen to you first and see what your priorities are and help you navigate those priorities. So that's how our staff is trained, and we're very proud of those things. We are now helping some other communities. We've helped 3 communities through an NIH, National Institute of Health, National Institute on Aging grant, through some Duke colleagues. I'm a Carolina girl, but I was sort of pulling for Duke, occasionally. It's hard, but I try. I wanted Margaret and friends to be happy, but anyway. So we had some Duke colleagues and had a huge grant to help replicate our program, and we did it in Pitt County, Buncombe County out east, Pitt out east, Buncombe in the west, and the central part, Guilford County. So we've helped them, but we're going to continue helping them, we hope, if we get some more funding to do that. They like the model. Many people like the model. We just need it replicated in one other place to have similar outcomes to us, and then it can be considered an evidence-based program. After people have been in our program 2 years, they decrease their hospital stays and their emergency room use by 1/3. Not only do they save money on their medicines, but people's health improves even though they're 2 years younger after being with our program. So we're very proud of that. They're real outcomes. Okay, now I'm here to talk about Medicare. So we are the SHIP coordinating site. So we've talked about who's eligible for Medicare, but what you should know is nobody in their right mind would have ever created Medicare like it is now. It is a patchwork quilt that started out, President Johnson signed it into law in 1965, and he was starting it to mirror what looked like Blue Cross Blue Shield at the time. Blue Cross was what covered the hospital. Blue Shield was what covered the outpatient services. So it was a very basic benefit for people 65 and older to cover hospital and some of their outpatient services. Then we added younger people with disabilities. Then we added hospice. Then we added home health. So patchwork after patchwork, including one of the more recent ones, which is 2006, when they added a drug benefit. Fee-for-service traditional Medicare does not cover hearing benefits, vision benefits, or dental benefits. Now, if you have glaucoma or you have macular degeneration, the disease is covered. Disease of the eyes are covered, but not routine dental, vision, or hearing. A lot of younger people don't know that. They're shocked. They've had employer coverage and they go on Medicare and they're just shocked that they won't have a vision or dental benefit and they can't have an annual, checkup. They get this chance to speak with their provider every year, but they don't get an annual physical per se. People are sort of shocked by that. The other major thing people are shocked at is that Medicare does not cover long-term care services and supports in the home. If somebody needs aid assistance and it's not medical, it is not covered by Medicare. Rehab for up to 100 days maximum is covered by Medicare. If you are improving or maintaining or compensating for lost function, Medicare will pay for rehab for up to 100 days. That's it. So you all know that because you're experiencing it. But a lot of younger people do not know that. And so one of the things she mentioned, I'm on a statewide, I was just sitting in the car taking a Zoom call because I co-chair the statewide effort to educate people about long-term care services supports and how it's not covered by Medicare. Who covers long-term care services and supports in the United States? Who's the major payer? You're all right. Okay, so private pay is the vast majority of it. Some people have Medicaid, so you're poor enough to not only have Medicare, but you have Medicaid because your income is so low. Only 5% of people have a long-term care insurance policy because they can be very expensive. Washington State is starting something where payroll deduction can go potentially towards a long-term care policy. If y'all remember, President Obama had something called the Class Act, where he wanted payroll deduction to go for a basic long-term care benefit, but it never got funded. Now, this is a bipartisan ignoring of what needs to be addressed. Long-term care services and supports, Democrats aren't talking about it, Republicans aren't talking about it, independents aren't talking about it. It's a huge unaddressed need in the United States. And it impacts us all because if you're not getting that care that you need to stay in your home, you may get sicker and you may need more expensive care. But we don't see those supportive services as investments as we should. I think senior pharmacists and what we do is a big part of that. I think what we do is something that makes a lot of financial sense. You put in $1.4 million a year, I guarantee you, our rate of return is 10 million, right? But we don't invest in those types of things in our country as well as we should. So Medicare is a lot of incremental change and patchwork. It started with again, this is what you hear about. Medicare's going broke next year. No, it's 10 years from now. No, it's 15 years from now. That's the Medicare Part A trust fund. That's what you pay payroll taxes for. So out of your payroll, $7.65 comes from the individual and from the employer to pay payroll taxes. Some of that goes to Medicare, some of that goes to Social Security. Okay, that covers that's just the hospitalization and what follows the hospitalization, including hospice and some home health. That's all that's paid for by payroll taxes. And by the way, payroll taxes, you can have payroll taxes or you can get Medicare if you've paid 10 years into the system, you or your spouse. And that spouse could be deceased, divorced, or you're still with them. Okay, you can use those credits to get Social Security. So that's 10 years of A. Part B and Part B is the outpatient services. That's the doctors, the outpatient. That only pays 80% of the allowable bill. The individual still owes the 20, and you pay a monthly premium for that. It went from $185 a month for most people up to $202.90 this past year. Many people pay more than that. You pay IRMA, Income-Related Medicare Adjustment Amount. I might see a lot of nods in the crowd. If you make more than $109,000 as an individual or $218 as a couple, you have to pay more for B and D. B and D are heavily, heavily subsidized. The average person paying $202.90 is paying 25% of the value of B. 75% of Medicare is subsidized by general revenues of the government. That's why Medicare is about 15%, don't quote me on that, I should know this, about 15% of the federal budget and growing. Because every day, about 10,000 people turn 65. By the way, we have fewer workers to support the people on Social Security and Medicare. When Medicare began, we had like 5 workers for every one person over 65. Now it's like 2.3 people working for every person over 65. Our government needs to wake up, our Congress needs to wake up around funding Social Security and Medicare. Medicare is heavily subsidized by the federal government, just like Part D, the drug benefit. I didn't say this was all good news, did I? I'm the messenger. Okay. So A is hospital and what follows, that's payroll taxes. B, you pay 25% of the value. People that pay IRMA get a subsidy, but not as much. So they pay more of the B and D. So B is the outpatient services. D is the drug benefit. Okay. And at the time, the Vice President of the United States, Kamala Harris, came to our office to introduce the Inflation Reduction Act. I got to introduce her on C-SPAN in 2022. She wasn't a candidate for anything, so that was all good. We are very happy with the Inflation Reduction Act as a group because what it did was it did a couple of really big things. It said if drug companies, this is a biggie that nobody talks about, if drug manufacturers for brand name drugs raise their prices faster than inflation, the extra money beyond inflation has to go back to the federal government to subsidize Part D. People don't know that. That's sort of behind the scenes, a major way we're funding Part D. Okay, that's the inflation rebate. The other thing it did, and this really helps people with very expensive medicines, like if you've got cancer or a lot of inhalers or a lot of diabetes medicines, it capped the annual spending somebody would have, regardless of your income, on your prescription drugs. Last year it was $2,000, this year it's $2,100. We were very happy with that. And the other thing the Inflation Reduction Act did was it added a ton of preventive benefits with no copay. A lot of vaccines, it lowered the cost of insulin to $35 a month so that people could get their insulin. So it did a lot of really wonderful things. Unfortunately, Medicare Part D and a lot of other Medicare things have meant that a lot of people see a way to make money off the system. Okay, so let's start with this. So about 50% of people are in fee-for-service traditional Medicare. When a provider sees you, you write down what you did for the person and you get paid fee-for-service. The more you do, the more intense the care is, the more that you get paid as a provider. Okay. More than 50% of people have left traditional Medicare and they've gone to these heavily advertised, privatized Medicare Advantage plans. There is nothing wrong with them, but you have to understand what they are. And maybe, has anybody here ever gotten a call from a potential Medicare Advantage plan? Okay. Oh, gosh, I find that shocking. Okay. That's right. So Medicare Advantage plans are privatized. They have A and B benefits, but they're paid for differently. They're pay as you go. The sicker you are, the more they cost you. There are co-pays. There is co-insurance as you get physical therapy. Potentially you do an outpatient physical therapy. Every time you do it, it's $25. If you go to the hospital, it's $350 a day on average. So it's pay as you go, okay? A lot of people love it because they're like, I don't have a monthly premium. It's all good. Except for when you get really sick, then you start paying. It does have a maximum out of pocket for a year. So it does cap. Traditional Medicare doesn't have a maximum out of pocket. You could go broke if you just had A and B. But if you're over here with traditional Medicare, you never want just A and B. You have to have secondary coverage, because here's Medicare A and B. They have holes, deductibles, that kind of thing. There are 3 ways to fill that hole. One, you could have Medicaid if you had very limited income and assets. Number 2, you could have an employer-sponsored plan from your employer. Or 3, you could purchase a Medigap policy or Medicare supplement. That fills the holes of traditional Medicare, okay? So don't be in Medicare A and without some sort of secondary coverage. Some people struggle to afford a Medigap, and there are only 4 states that give you rights to that Medicare supplement after 6 months of starting B. Some people can be denied coverage. You could be in a Medicare Advantage plan and decide you want to leave. In North Carolina, we don't protect your rights to get a Medigap policy without underwriting. Does anybody know what underwriting is? Yeah, insurance companies asking you questions about your health and using that, often using your claims data or your prescription data, and seeing that you have conditions and jacking up your rates because they can, and charging you more because you're sicker. That's called underwriting. Sometimes they deny you coverage altogether in the state of North Carolina. If you want to not be denied, you need to move to Connecticut, Massachusetts, or New York. They have rights that say to insurance companies, you cannot do underwriting at these times of the year. You've got to let people in a Medigap plan, but not in North Carolina. Now, if we did say, hey, let people in, what would that do to everybody else's rates that are on Medigap supplements? They would raise them. So all of these things have trade-offs, right? Okay, look, back up here. That's fee-for-service Medicare. You can have employer secondary coverage. You can have Medicaid. You can have Medigap, traditional Medicare. Anybody will see you. You don't worry about there's no max out of pocket if you have secondary coverage. It's a moot point. You don't care. And you've got great coverage. Okay. Here are these people over here. These people are in a Medicare Advantage plan. I may need one if I fall off this thing here. You're in a Medicare Advantage plan. It's a privatized plan. It could be Humana, Aetna, whoever. There are 2 flavors. There are HMOs. You've got to stay in the network. If you go out of the network, you owe the entire bill. Those are tightly wound networks. The caveat, though, or the exclusion of that, if you ever have an emergency, if you're in a private Medicare Advantage plan, you have an emergency or urgent care, it's always in network. You don't have to worry. Okay. But otherwise, if you're in a Medicare Advantage plan, it's a HMO, health maintenance, you've got to be in network, and you need referrals often from your primary care provider to go see a specialist. Or it's a PPO. If you're in network, no problem. If you're out of the network, you're going to pay more to go do that, but you have more access. Medicare Advantage plans are getting rid of their PPOs. They're moving everybody to Medicare HMOs. Many of them are. Okay. Many of them in the middle of the year are ending their contracts with certain providers. And that creates problems. It does create rights too, but it does create problems for people. So not only are there networks, but they can end in the middle of a year, and then all of a sudden the provider you were with no longer takes this insurance, which is a huge problem, and we help a lot of people figure that out. But they also have something called prior authorization. Okay. That means before you can go get X, Y, and Z, it needs to go through your primary care doctor, and then the insurance company needs to approve it. A lot of providers, it's created headaches for them having to deal with prior authorization. Okay. Medicare Advantage plans aren't bad. They can cost very little monthly, but as you get sicker, you're going to pay more as you go. You've got networks to deal with, and you've got prior authorization. They also have perks, hearing, vision, dental. A lot of them come with a cash card. So you can go buy over-the-counter stuff, groceries, pay your rent. So a lot of people with very limited incomes tend to like some of these Medicare Advantage plans. The MedPAC just came out in March with the statement. It just came to the press last week. that we think we overpay these plans. Now we think we overpay them 14%. That's $76 billion we're overpaying them in 2026 alone. Now think what we could do with $76 billion to improve Medicare. We could add a vision, dental, hearing if we stop the overpayments. We're overpaying them for two major reasons. One, they upcode. So the insurance companies have incentives to make the person look really sick. So they send a nurse to ask you questions. They ask the pharmacist to ask you a bunch of questions. They check a bunch of boxes. Let me give you an example. I had plantar fasciitis years ago. I haven't dealt with it in 15 years. But if they look through my medical record or ask me questions, I did have it. So they put that on their checkbox, then they get paid for me having plantar fasciitis, even though I hadn't dealt with it in a few years. So it's called upcoding. It's not that you never had it. It's not a lie. It's just, they're not dealing with it now. The other big thing is called favorable selection. We think that a lot of people, when they're in a Medicare Advantage plan and they start getting sick, they go back over here. So you have healthier people that are in Medicare Advantage, but when they start getting sicker or they deal with network headaches or prior authorization, they try to run back over here and get to traditional Medicare. Okay, I'm getting ready to get to my crystal ball, and I know if you have questions, I think please pay them put them on a card. I think we'll get to that. No one would have built Medicare this way. We pay more. I bet you've heard this. We pay more for health care than any other country. Sometimes 2 to 3 times more. What you don't hear is that we pay about half as much as others on social care, housing, transportation, food assistance. Do you know what waiting lists we have for food assistance in North Carolina? Do you know how stingy what used to be called food stamps is? You cannot have more than $2,000 in savings to get any help with food assistance. We strip people of all their income and assets to give them any federal assistance with these programs. And we have long waiting lists. So yes, we pay too much for health care. It's a jobs program, by the way. We got a lot of people in healthcare and a lot of AI people now in healthcare. A lot of people in healthcare because that's where the money is. That's where the money is. Unfortunately, we don't support the social care and the things that, quite frankly, bring quality to your life. We have a lot worse outcomes. We rank 36 compared to other OECD countries when it comes to overall health for older adults. I mean, for just everybody, all ages. So we are not hitting the mark on that. So there are a lot of vested interests in healthcare. We have allowed healthcare to be a for-profit business, which is very unusual compared to other countries. So here's my crystal ball. I think we're going to have to move to what's more risk-based contracting. And what I mean by that is that you're going to have to get hospitals, insurance companies, and providers have attributed lives to them that can't change from year to year to year and say, you're responsible for total cost of care. Because otherwise, everybody's just playing a game. It's like whack-a-mole. Insurance companies like, these people are getting kind of expensive. Let's stop offering that in Durham. Let's code them differently. When you have payment systems that people can follow the money to easily, they do. I hate to say it. But we have systems that we have too easily allowed people to manipulate, whether it's the insurance company, hospitals and insurance companies and pharmaceutical companies. We have let them have way too much what we call vertical integration, where they, hospital buys physician practice and the insurance companies buys the pharmacy and buys the PBM, and they only send you to their family and friends, where they pay them more, right? And it's just raising the cost of health care for people. So until we have true risk-based contracting where everybody's in and could lose if they don't do a good job, I just don't know how Medicare is going to get itself improved. I'm going to stop and take questions because I've gone over too much. We do have ways to volunteer senior pharmacists. One is on our development fundraising committee. One is helping with outreach because there are a lot of people in Durham that do not know we exist. And that's so frustrating. So if you can help with outreach or help in the fundraising development piece, we'd be happy with that. And I'm happy to answer any questions. I've got a lot of more crystal ball ideas, but I think I want to leave it to questions.
So much, Gina. Can everyone hear me? Almost. Okay. I'm going to try to look toward you and hope that you can hear me, and if you can't, let me know. So some folks are going to collect the cards where you may have written questions for Gina. I hope so. But let me start out asking something that I know has concerned a lot of us, is that we're hearing more and more about scams involving Medicare. Can you tell us, as senior citizens all ourselves, what we should be aware of and what we should be looking out for?
Thank you, Diane. That is a tremendous public health problem. Up until a year and a half ago, we could say, when I was speaking to a group like this, Medicare and Social Security will never get in touch with you unless you called them first. So that used to never happen. That changed with the current administration. They started sending out notices, letters, and they're like, we're in the 21st century. We're going to communicate with people via electronic means. It has opened up Pandora's box to a lot of scams. No one should ever ask for your passwords, ever, for anything, unless you call them. Never. Okay? Nobody should ask for your Social Security number. Assume if somebody's calling you and saying they're with Medicare that they are not. Just assume it. There are so many scams. The banking. So we hear it all the time. A lot of people come into our office with a bag of mail going, is this real? And people will often do envelopes and that kind of thing to look like they're from CMS or Center for Medicare and Medicaid Services when they're really not. They're like red, white, and blue and this kind of thing. So watch it. Don't give out anything over the telephone unless you called these people first. They should not call you and just say, put it in writing to me. And even then be suspicious. So we're hearing a lot of it.
What percentage of Medicare payments are estimated to be fraudulent?
Ooh, that's a good question. What's so frustrating too? The question is, what percentage is fraudulent? I don't remember. We did look at that. I can't remember. Something like 5%. It's a lot of money. It's a lot of money. And it's very frustrating. Like, my mother died in 2023. And I'm paying attention to her explanation of benefits. Okay, by the way, that's one thing that's changing with the big budget bill. You used to get an explanation of benefits like every month. You're not going to get that but twice a year now. So good luck remembering what happened, right? Your insurance company should still send you, if you have a Medigap supplement or something, your insurance company, but CMS won't send out that very confusing explanation of benefits. Like, here's your A cost, here's your B cost. So they're only going to do that twice a year. But I noticed on my mother's, well after she'd passed, they said before she died, she ordered a bunch of COVID tests. Well, my mother was not capable of ordering those COVID tests, and I was ordering the free ones on the government website, not through Medicare. So I knew it was a total scam. So I called to complain about it, but a lot of that happened. I don't know if you all have heard you heard about the skin substitute. People are like having some sort of wound, and they use this very expensive skin substitute that doesn't have very good data. And so a lot of doctors were doing that, and that was totally fraudulent. A lot of people are being billed for urinary catheters that don't use catheters. So do look at your insurance forms, and if you don't recognize some of it, it's worth a call. Great question. I think it's about fraud is about 5%.
Do pharmacy benefits managers increase costs?
Yes, I'll repeat it. She said, does pharmacy benefit managers increase costs? Pharmacy benefit managers are a main middleman. You hear them called that. So if you think about it, when senior pharmacist gives people this card, well, the pharmacy, when they go to the pharmacy, somebody has to make sure that they can bill for Eliquis for $20, because that's what we approve. But don't bill for Eliquis for $10 because we want their copay to be $20. Somebody has to make that happen, that the right drug is, covered on formulary, that the right copay goes. That's called a pharmacy benefits manager. The other good thing of a pharmacy benefits manager, it's an electronic sort of company behind the scenes. If you go to the CVS and then you go to the Gurley's and there's a drug interaction, the pharmacy benefits manager can tell the second pharmacist you have a drug interaction. So there's a real reason to have them, but they were being paid. This is a big thing that the Inflation Reduction Act fixed. They were being paid based on list price of your medication, not for fee for doing the service thing. So if you took a $1,000 medication, they made a lot more money than if you took a $100 medication. So they should have been paid on transaction, per transaction, and that's shifting. Some of the bills, not the balance, not the big bill, but some other bills have been added to rein in pharmacy benefits managers. Because what they were doing, they were in cahoots with many of the insurance companies and the drug manufacturers to raise prices, because then they got a percentage of the cost and we're making money off that. So we're trying to stop the percentages and just say you should get paid for the job that you do and not based on list price. I don't know if y'all remember Tom Scully, but he was somebody that was very involved when we got Medicare Part D, and he even said, average wholesale price, that's one of the list price of a medication. Average wholesale price, you know what it stands for? Ain't what's paid. It's just a made up price that the drug manufacturers make up as their list price. They have pharmacy benefit managers. Not only have they been making a lot of money themselves, they've been ripping off community pharmacists. And I have written several articles about this, and one's getting ready to come out in a large journal. And it really has hurt a lot of local community pharmacies. They have these things called direct and indirect remuneration fees. They go to the pharmacist months. It used to be. Now they have to do it ahead of time. They used to go months after the medicine was dispensed and say, you didn't do X, Y, and Z, and we're going to audit you and take a lot of your time, and we're going to take some money back from you. It was horrible. So a lot of independent pharmacies have closed. So that's gotten better and a lot more attention. Great question.
We have several questions that involve Medicare Advantage, various aspects of Medicare Advantage. One of them is that with Medicare Advantage costing so much more, how does that affect the funding for traditional Medicare?
Great question. So Medicare Advantage, as I said, we think we're overpaying at 14%. So that's $76 billion. Everybody's paying for that because Medicare B and D are paid in two ways. One is your Part B premium went up to cover that overpayment. Went from $185 for most people to $202 and that's like a 9% annual increase. That was huge. So everybody, whether you're in traditional Medicare or Medicare Advantage, your Part B premium went up. And general revenues of the federal government pay for 75% of it. That had to go up to cover the overpayment. So all citizens in the United States are paying for that overpayment, and including particularly the Medicare Part B premiums that individuals pay.
What if you decide that you don't want to be in Medicare Advantage and to switch back to traditional Medicare? Are they required to take you?
Great question. And the answer in North Carolina is no, they are not, unless there are certain things that happen. And they're called special enrollment periods. And that's what senior pharmacists is really good at. We kind of look around and see if we can find something for you to get back over to traditional Medicare and get a supplement and a drug plan. By the way, getting a drug plan is optional. You don't have to, but if you don't have credible or good drug coverage from somebody else, you may pay a penalty when you finally do join. So, but it is optional. So if you're in a Medicare Advantage plan and you want to leave it, you don't have rights without underwriting. If you're fairly healthy, that's really not going to be much of a problem. If you have some significant conditions, they could deny you or jack up your rates. We tend to know the companies that are better at being a little more generous than others, especially as we age. So we try to help people finagle that. If your Medicare Advantage plan leaves the area, if they misrepresent something, if you move, there are lots of reasons you have rights to get a Medigap supplement. So we can help people sort through that. So here we go. Senior pharmacist tagline is know your meds, know your meds, know your coverage, know what kind of coverage you have. Are you in traditional Medicare? Are you in a Medicare Advantage plan? If you're in traditional Medicare, do you have secondary coverage? What is it? Know your meds, know your coverage, know your rights. When do you have the right to certain things? So that's what we study. And by the way, all of these rules change every year. The benefit structure changes, the amount of the benefit changes. It's like crazy, but it's a full-time job. Good to see you.
A number of us here are retired state employees of North Carolina, particularly people who are employed by that university down the road. And so there's a question about the Medicare Advantage plan that is offered by the state. It's considered a special plan. Is that the same as other Medicare Advantage plans?
You'll have the best questions. No, it is the best of both worlds. So when you have traditional Medicare, you could have an employer that has a secondary plan that's just traditional Medicare. Or your employer, like the state health plan a few years ago, and all chaos broke out because everybody's like, oh my God. So went over to a Medicare Advantage plan, but it's not a commercially available. Joe Blow can't go out and purchase that. It is your employer, the state of North Carolina, dictating to a company, this is what you will do, and this is how the plan's going to go, and you need to administer it. So the North Carolina State Health Plan, retiree coverage, is decided on by the state, and they hire Humana to administer it. It's not a Humana Medicare Advantage plan. It's an employer-sponsored group health plan administered by Humana. It has an open network. So even though UNC Chapel Hill no longer takes commercial Humana or commercial Cigna, they take the state health plan from Humana because it's just being administered by Humana. So somebody else came up to me earlier asking me about their retiree coverage from another state that's a Medicare Advantage plan. So you have to just check with the Forest at Duke to make sure they take it, but they often have open networks, meaning anybody that will take the insurance can take the insurance. That's very different from Medicare Advantage commercial HMOs that have a tight network. Great question.
So if we have questions and call Medicare with the reduction in federal employees, is anyone going to answer the phone? And how long will it take?
Well, let's put it this way. Answering the phone at CMS or Medicare may be better than at Social Security. Is that an answer? I don't know.
Not a very encouraging one.
Yeah, it's a problem. It's very frustrating. Yeah, I don't know how to answer that. It's not good. Call us instead. Okay, there you go.
Medicare has been well accepted in this country. Is it a viable model for universal health care?
So when you say Medicare, I don't know if you're talking about Medicare Advantage, if you're talking about fee for service. So when people say Medicare for all, I just have a stroke. I'm like, which part of Medicare are you talking about? Because Medicare is different pieces and parts, and it's administered different ways. It is, and it was intended to be the first step to universal coverage. There's a fellow, if you're talking about interesting speakers, y'all need to get John Oberlander from UNC here. He teaches the social he is so good. Oh my gosh. He's written a book about Medicare. And he talks about, he's wonderful. He teaches in the social medicine department of the School of Medicine. He talks about Medicare, when it first began, as I said, it was supposed to be the hospital and outpatient services like Blue Cross Blue Shield. And then they were going to add the children, and it was going to be called kitty care. So there was going to be Medicare, and there was going to be kitty care. People sign up their cats. Okay, she may know the history of it better than I. KIDDY, kitty care. But it's all politics, right? It's all politics, and people saw that they could make money off of it. Where there is money, there is a way. And so, and they were going to have Medicaid, like help. They decided. So one of the things was they started with older adults, then they pivoted to Medicaid to help poor people, and then it all fell apart because they're like, everybody's like, well, that's not my own interest, so I'm just not real worried. So it was supposed to be the first step in universal coverage. We never got to the second step, which was supposed to be kitty care, because they made a brief introduction of Medicaid. And Medicare is a federal program. It's administered federally, a lot of federal funding. Medicaid is mostly federal funding, but it's administered by the states. So depending on what state you're in as to what you're eligible for. And that's a whole nother talk, and that's a whole nother issue we're having. North Carolina is the only state in the country that does not have a budget right now in place. So we don't know what's going to happen. Okay, so the balanced budget bill didn't do a ton to affect Medicare. It has major implications for Medicaid. It is, instead of having the overworked social services office check people every year for eligibility, they're going to make them do it twice a year. So they're already overworked, but now we're going to make them do it twice a year. The Affordable Care Act plans. 15% of people have Medicare, 17% of people have Medicaid, 7% of people have independent, their own insurance. 50% of people have employer-sponsored coverage. Okay, but these people who rely on individual policies that are part of, the Affordable Care Act plans, they had subsidies that would go. You would start with very limited income, and it would go up to about 600% of the federal poverty guidelines. Still, people who made about $7,000 a month, they could get some sort of subsidy. January 1st, hatchet came down. If you make more than 4 times the federal poverty guidelines, you're getting no assistance by insurance. My friend, who's been very successful, lives in Chapel Hill, independent consultant, went from paying $300 a month for a high deductible health plan. She's 63, like me. Had a $5,000 deductible, but she was paying $350 a month because her income's not regular, to paying $1,300 a month for a high deductible health plan. So the balanced budget bill that was passed shut down helping people who aren't poor, but middle income folk. So you will hear, it's called cost sharing reductions with the Inflation Reduction Act or marketplaces. So you're going to hear a lot of conversation about that. And it also makes it harder, not only, and I should tell you one thing about Medicaid. So Medicaid, you're going to have to apply for it. People are going to have to apply twice a year instead of once a year, administratively burdensome. And a lot of people have to show work requirements. Well, a lot of people on Medicaid can't work for whatever reason. I want to make sure you understand this. If somebody is helping a family member or somebody else that needs long-term services and supports in the home, they can get that requirement waived. Because helping somebody, even as a volunteer in the home, or if you're being paid as a direct care worker, helping somebody in the home, and you're on Medicaid, that counts as work, even if you're not being paid. Does that make sense? So that is one thing that we got slid into the bill.
So the last question is, can you tell us a little bit about your last recent congressional committee meeting and the issues involved? And I don't know how you're going to do this in a very short period of time, but maybe you can sum up quickly for us.
No, I can. The last meeting we had is really teeing up a meeting we have in a week and a half, and it's our last meeting of the year. And the hot topic was the one that I'm really the consumer advocate. I'm a pharmacist, so I fill a pharmacist role, but I'm also the consumer advocate, because most of these people have a PhD in economics, head of Harvard's, health policy. I mean, they're policy wonks and economics people. I was told I was the only person who's ever come to a MedPAC meeting with props. I came with some of our some of our cheat sheets to help people navigate Medicare. So at the next meeting, we're going to be talking about helping people navigate with the SHIP program. So at our last meeting, it was as we were releasing the March report that talks, we have 2 books that we write once a year, each of them once a year. The one that came out in March was what we were just reviewing. So it's how much should we pay for 8 different services: inpatient hospital, outpatient, physician payment schedule, hospice, home health, rehab facilities, end-stage renal disease, and I'm missing one other. That's the March report, so we were finalizing that. And then April, we're finishing up chapters that come out in June, and that's the more interesting stuff, right, around consumer choice. Why do people have so much choice? I'm going to leave you all with a quote from one of my favorite participants. He's a farmer. He was a farmer. He's deceased now. But he said to me when I was helping him with Medicare one time, he said, "Ma'am, gracious, I like choice. Choice is fine. But I wanted to choose between paper and plastic, not all this mess." And I said, that is the best quote. I said, "Can I play?" And I've said that several times at MedPAC meetings, so people get a kick out of my stories. But it is those stories and the narratives of real people's lives that is why I feel like I bring a little value to the MedPAC, because otherwise you're just sitting there talking about policies and not how they really impact people's lives. So we've been given the gift in Durham that people let us into their lives, all incomes, all ages, understanding Medicare, so that we can have a little bit of a voice at a larger level. So we're very thankful for that.
Well, Gina, you've certainly brought value here. Thank you.